Hey podcast listeners, Jim Siegler here for BrainWaves, a podcast about neurology and medicine and all the fascinating science and history that come along with it. Today on the program, as part of our Quanta series, where we cover brief but high-yield clinical updates in neurology, I'll be discussing the recently published results of the TOLEDO trial. But before we get into those results, here's a little bit of background on what this study accomplished, and why or why not a study like this was needed. So let's get right into it. So, TOLEDO was a randomized, double-blind, multicentre clinical trial of patients with Parkinson disease who were treated with 12 weeks of either subcutaneous apomorphine injections or placebo. Apomorphine, as you might remember, is a potent dopamine receptor agonist, and it works across a broad range of dopamine receptors in the central nervous system. And like other dopaminergic therapies, like levodopa-carbidopa, it replaces the lost dopamine from the substantia nigra as Parkinson disease progresses. And what we know from other clinical trial data and from observational studies is that as the disease progresses, there are more fluctuations of on-off cycling. Patients can develop more frequent and longer bouts of rigidity, admixed with more disabling and uncontrollable dyskinesias as the patient responds to the dopamine replacement. And to combat this, we've engineered ways to maintain a more steady state of dopamine agonism by increasing the frequency of levodopa dosing and by using MAO-B and COMT inhibitors, which prevent dopamine degradation. And we've also developed longer-acting formulations and even continuous intestinal infusions using a levodopa-carbidopa gel. And then, of course, we have deep brain stimulation. And we've covered all these therapies in a prior episode, number 32 with Dr. Coughlin. And included among these options of more continuous targeted therapy for PD would be subcutaneous apomorphine. Now I'll start by saying that apomorphine is not a novel medication. It's been licensed for use in the UK for treating Parkinson disease since 1993, and this was based on the results of an open-label comparative study that showed that apomorphine was as effective in PD as levodopa was. And subcutaneous, delayed-release formulations of apomorphine have been shown to reduce the off time by as much as 80% in some treated patients. However, despite this 20-plus year history of demonstrated safety and efficacy, there remains no Class 1 evidence that it's better than placebo for managing Parkinsonian symptoms. Until now. In the TOLEDO trial, which was published online in Lancet Neurology in July 2018, investigators at 23 hospitals in Europe enrolled adult patients with PD who had at least 3 years of neurologic symptoms. Importantly, patients were only eligible for inclusion if their oral medications were not adjusted in the previous month, and they had to experience at least 3 hours of total off time in the days prior to baseline screening. 100 patients were eventually screened for inclusion, and 107 met criteria and were randomized. The infusion dosing of apomorphine was titrated on the patient level to a therapeutic response over a 4-week period, and the final rates of the infusion ranged from between 3 and 8 milligrams per hour for the next 8 weeks, with infusions continuing only during periods of wakefulness. Patients in the trial were allowed to reduce the doses of other PD medications if they had symptoms of dopaminergic toxicity, like dyskinesias, nausea, orthostasis, or sleepiness. And after patients completed the 12-week double-blind phase of the trial, they could be enrolled in the 52-week open-label study period. So what's so important about this trial? The primary efficacy endpoint was the absolute change in off time from a baseline of 3 or more hours to ideally something that was going to be a lot lower in the treatment arm. Of the 71 patients who completed all 12 weeks of the double-blind phase, those treated with apomorphine had a 2.5 hour shorter off time at 12 weeks than at baseline, compared to a half an hour of off time in patients who were treated with placebo. An average of a 2-hour daily improvement in symptoms of rigidity and freezing with the use of apomorphine. And next, we've got to ask ourselves, with the addition of another dopaminergic therapy, were there other issues with toxicity? Unsurprisingly, patients who received apomorphine would eventually require less oral levodopa at the end of the trial period when compared to patients who received placebo. There was also a shorter average duration of the troublesome dyskinesias with apomorphine, 2 hours a day less of those disabling hyperkinetic movements if you received the study drug. And that's probably because these patients required less intermittent amounts of oral dopamine replacement. There was a nice overall clinical response to the placebo if you look at the Kaplan-Meier curves from the paper. But compared to even this placebo response, the changes experienced by patients who were treated with apomorphine are far more robust. Of the pre-specified subgroups, there was no difference in clinical response to apomorphine among older patients versus younger patients, or in males versus females. And all this sounds pretty impressive. Significant improvements in the motor disorder symptoms. But how did patients subjectively feel with the apomorphine? Well, the investigators looked at this too, and they used a validated survey tool, the Patient Global Impression of Change, which is used for many diseases and different treatments. And what the investigators found was that patients who received apomorphine responded more favorably to this treatment, indicating that they felt as if the medication were working. Furthermore, 71% of patients who were treated with apomorphine said they believed that their general state of health was improved, compared to only 18% in the placebo group. So yeah, this sounds great. Kind of what we were all hoping for with this kind of trial. Better on-off control with apomorphine, better dose reductions in dopaminergic agents, and subjective improvement. But let's also acknowledge some of the side effects to the medication and some of the weaknesses of this study. While a continuous apomorphine infusion was well tolerated in general, almost every patient in the treatment arm had an emergent adverse effect, 93% of patients. Compare this to 57% of patients who were treated with placebo. Now you should probably ask yourself, why did over half of patients who received placebo have an emergent adverse event? Kind of a curious thing, but of the treated patients, most of the adverse events had to do with local skin changes, like swelling around the inoculation site. And 60% of patients had this. Many of these events were mild, but they were enough for the investigators to worry about. Other relatively common adverse events were nausea, 22% in the treatment arm versus only 9% in placebo. Somnolence, also 22% among those given apomorphine. And a few patients had headache or other minor events. Half of patients who received apomorphine actually had their dose modified because of these events. So I cannot say that it's a perfectly safe medication. It seems that, according to the investigators, that the drug was associated with clinical and subjective benefits. And although the adverse events were common, most patients underwent dose adjustment, and they probably felt well enough at the end of the 12-week observational period to then enter that open-label phase. And while these safety events are always a concern, regardless of whatever medication you're scrutinizing, the TOLEDO trial does have some important limitations. First of all, there was a lot of dropout, or attrition bias. Of the 107 patients who were randomized, only 71 completed the 12-week study period. One patient dropped out early before the intervention, and 18 of the 106 patients prematurely converted to the open-label phase. They desired the real drug. And largely, patients converted to the open-label phase due to concerns about drug efficacy. While the investigators of the trial appropriately acknowledged that far more patients in the placebo arm ultimately converted to open-label therapy than patients in the treatment arm, 16 versus 2, there were also 12 patients in the treatment arm who did not complete the 12-week trial due to concerns about drug efficacy or side effects. And this attrition bias may seriously confound the results if you think about how the only patients who completed the study were really just those ones who could tolerate the adverse effects, if they were in the treatment arm, or if they were the ones who didn't drop out because they thought the real drug wasn't working. 30% of patients were lost to this kind of bias. Another important limitation of the study is that the study was conducted in a region of the world where apomorphine was a standard of care, and many patients were already taking at least one dopaminergic therapy or multiple therapies. Therefore, the risk of pro-dopamine side effects were obviously greater in this setting. And furthermore, patients also knew that they had a therapeutic out if they didn't like the study. Whenever they wanted, they could just drop from the study period and be prescribed apomorphine. Importantly, this study was the first truly randomized, placebo-controlled clinical trial that tested subcutaneous apomorphine against placebo in patients who've had several years of Parkinson disease. The reduction in the off time with apomorphine came with better control over dyskinesias and lower doses of other dopaminergic therapies. And while this study is not without its own significant limitations and a high rate of adverse events, which led to drug discontinuation for nearly 20% of patients. It has finally put to rest the question of, can subcutaneous apomorphine be used to effectively manage the on-off fluctuations of PD? I asked one of the movement specialists I work with, Dr. Andres Dake, what his thoughts were on the trial, and this is what he said. Subcutaneous infusions of apomorphine have been available in Europe for some time and are currently in phase 3 clinical trials here in the US. While it's helpful to have this data, I don't believe it'll change clinical practice in Europe. Once the studies in the US conclude, and if positive, the subcutaneous infusions do have the potential to disrupt the space here in the US. Eventually, as the final results of the open-label component of this investigation are published, we should have more insight into the tolerability and the safety of apomorphine as an adjunct in PD. Hopefully, with more fine-tuned adjustments to a patient's PD regimen, the side effects of dopaminergic therapies may attenuate, the motor fluctuations regress, and the subjective benefit perceived by patients lead to a better quality of life. Where previously apomorphine availability and reimbursement may have been a concern, hopefully the TOLEDO trial has remedied this. That's all we got for you on the show this week. Thank you so much for listening to the BrainWaves podcast. For more information about the basics of managing PD, please refer to our prior episode featuring Dr. David Coughlin, episode number 32. Or for some history about PD management, check out the show where we reviewed the incredible history of levodopa as a pharmacologic agent. The BrainWaves podcast is produced out of Studio 3 in Philadelphia, Pennsylvania. Jim Siegler, senior producer. Music for this week's program was courtesy of Androsic and Rod Hamilton under a Creative Commons license. Sound effects by Mike Koenig and Daniel Simeon. I'm Jim Siegler. Thanks for listening.